So I should start by saying I'm a hematologist in Adelaide, and as some of you will know, Adelaide has had a very strong research interest in CML. So I was a PhD student with Tim Hughes and Junior Mello and Susan Branford, and I've maintained a research interest in CML, and we still have a number of CML trials in Australia. So in my talk, I'm going to talk about the major clinical trials, starting with the original IRIS study, which compared imatinib with interferon, and then moving through to some more recent studies. I'll talk a little bit about monitoring, very briefly about choosing second-line treatment, because I think that my colleagues will talk about this in some more detail in the next talks. Very briefly, for interest, I'll talk about some newer treatment options, which I think are potentially very exciting. And I'll finish with a summary of the European Leukemia Net guidelines for optimal therapy. So we've already seen this before in the answer to some of the questions in the quiz. So this is the BCR Abel gene shown as a cartoon. So you can see here is the BCR gene on chromosome 22 on the left and the Abel gene on chromosome 9. So the regulatory portion of BCR is bound to the enzyme part of BCR Abel, so that you then produce this completely new BCR Abel enzyme, which only exists in leukemic cells and not in normal cells, which is why the therapy is so perfectly targeted. And the BCR Abel gene then encodes the BCR Abel protein, which is this abnormally activated enzyme. So because the BCR Abel gene is present in every patient with CML, it gives us something that we can measure so that we can accurately determine how that particular person is going in response to his or her therapy. So this is an average of the kind of responses that we see from large numbers of patients treated with imatinib. So the average on the international scale at diagnosis is 100%. We expect that in the first few months, most patients will drop below 10 or even 1%. And then after this very rapid drop in the first few months of treatment, we then see a slower continuing fall, which can go on for many, many years. So some people are still having a very, very small reduction in the level of BCR Abel, even after 3, 4, or 5 years of treatment. So there's this rapid initial phase, and then this slower gradual creep, which eventually leads to some people having undetectable disease after a number of years of treatment. Oh, and I should point out that a reduction to 0.1%, a 3-log reduction, is termed a major molecular response. And I'll come back to this in a moment, because this is a major endpoint for CML treatment. So the original study that compared imatinib with the previous best available therapy, which was interferon, with or without combination with cytarabine, showed that imatinib was far superior. I haven't actually shown the interferon results, but the interferon line would be down here somewhere by 5 years. So only about 5% of patients in the study died from complications of CML, and a similar proportion of people died from other reasons, because having CML doesn't make you live forever. You can still be run over in a car accident, or other things can happen to you. But this, compared to any previous therapy, was just fantastic. Very, very few people dying from their leukemia, where most people would have died within 5 to 7 years in the past. And in a subsequent study from IRIS, 3 laboratories around the world, one in Adelaide, one in the States, I think, and one in London, exchanged samples, and this was the beginning of the international scale. So what they found was that if you looked at people who had achieved this major molecular response, so a reduction in BCR Abel of 3 logs from the baseline, that when you look at the survival free of progression to accelerated phase, according to whether or not they had a major molecular response after 12 months of treatment, you can see that people with a major molecular response, no one died or progressed. So that brought about the idea that a major molecular response is a safe haven. If you've reached this level of therapy, the chances of something going wrong with your leukemia, they're not really zero, but they're extremely low. It's very rare for anything to go wrong after someone has achieved a major molecular response if they continue with that therapy. In contrast, people who had achieved a cytogenetic remission but didn't have a major molecular remission, they still did very well because a complete cytogenetic remission is already a good response, but they didn't do quite as well as the MMR patients. And people who hadn't achieved a cytogenetic remission with no Philadelphia positive cells detectable in the bone marrow, these people had an inferior progression-free survival, but still better than it would have been with interferon. So this is the origin of the major molecular remission, seeing that once people had achieved this level of 1,000th of the amount of remaining leukemia, that the chances of things going wrong were quite low. Now, you will know that the vast majority of people with CML are diagnosed in the chronic phase, and many people in chronic phase have no symptoms at all. They don't even know that they have leukemia. So sometimes the spleen will be slightly enlarged, and that can sometimes cause some discomfort. The white cell count will almost always be elevated, and occasional people will have other vague symptoms like feeling tired, sometimes some night sweats, occasionally nosebleeds if the white cell count is very high, but many people just don't know. And particularly in countries like Australia, where people have blood tests on a regular basis just because they have an annual checkup or something, most people are discovered before they have any symptoms at all. Over time, without treatment, the disease can progress into the accelerated phase, where the number of immature cells in the blood increases, people have more symptoms, and the spleen gets bigger. And the accelerated phase can then lead on to a blast crisis, which looks like acute leukemia and is usually fatal within 3 to 6 months. So if you only had chronic phase, you'd be reasonably well. Once you move on to accelerated phase, the chances of dying from the disease are significantly greater. And so what this shows is that for those people who are unfortunate enough to progress to the accelerated phase, the average survival is still really quite short. So most people who progressed to accelerated phase in the IRIS study and in the nilotinib study that I'll be talking about in a moment, around half of those patients died within 11 months of developing accelerated phase. So the major key of first-line treatment is to stop progression to accelerated phase or blast crisis, because it's accelerated phase or blast crisis that leads to death. If you remain in chronic phase, you're very unlikely to die from your leukemia. You're more likely to die from something else. So this is an update from the IRIS study, and it's actually been updated more recently again. And so what this shows is event rates, where events are loss of a response, progression to accelerated phase or blast crisis, or death from some other cause. And the accelerated phase or blast crisis is highlighted in black. And what this shows is the number of years after reaching a cytogenetic remission. So you can see that in the first year after achieving a cytogenetic remission, around 2% of patients might still progress to accelerated phase or blast crisis. So it's rare, but it's not impossible for this to happen. And then with every year that passes, the risk is getting smaller. So if you've reached a safe level of response and kept it, every year your risk of things going wrong is getting less and less, which is really fantastic to see, because of course we were worried when Gleevec was first invented, we were worried that it would be like an antibiotic where if you have long-term treatment, eventually the disease will become resistant, because that's what happens, for instance, with diseases like tuberculosis, that it eventually becomes resistant to what were first effective treatments. In fact, we're seeing the opposite here, that if you are not resistant in the first year or two, you probably never will become resistant. And this is very reassuring. Now, I talked about interferon as being the previous best available therapy for CML, and that's actually not quite true. It was the best available drug therapy, but the best available therapy overall was an allogeneic stem cell transplant, where we replace your bone marrow with bone marrow from a brother or sister, or sometimes from an unrelated donor. And so back in the 1990s, if you were young and fit and had a suitable donor, the standard first treatment would be an allogeneic stem cell transplant, and we know that this would cure a lot of patients. So the German CML group did a study in which they compared best available medical therapy, which at the time of starting the study was interferon, but later switched to imatinib, with transplantation for people who had a suitable donor. And so what you can see here is that the survival curves, and this is the chances of being alive, the survival curves are almost identical. So even when people started with interferon, which is not as good as imatinib, it was medical treatment was as good as being transplanted. And we can expect that for people who are starting now with imatinib or with another TKI, it's likely that transplantation would be inferior. And so essentially, since the TKIs came into CML treatment, allogeneic stem cell transplantation has almost stopped, except for people who have become resistant to tyrosine kinase inhibitors. And in that group, it's still a very important therapy. So I've shown you the kind of results that we can achieve with imatinib in the IRIS study. So the original dose of imatinib was 400 milligrams once a day. So this study from the German group tested whether you could do better by increasing the dose of imatinib or by combining imatinib with another treatment. And the other treatments that they tested were cytarabine, which was previously combined with interferon, or interferon itself. So this slide's a little bit hard to read. I'm afraid the pictures aren't really big enough. But what you can see here is that none of the combinations was significantly better or worse in terms of overall survival. So if you've got CML, your chances of being alive in 5 years are pretty much identical whichever of those treatments you received, imatinib 400, imatinib 800, imatinib with interferon, or imatinib with cytarabine. If you look here at a deep molecular response, so this is MR 4.5, or a level of undetectable or below 0.003%, so a very deep level of response. This light blue curve is high-dose imatinib, so you can see that imatinib 800 milligrams a day did a bit better than imatinib 400, which is this dark blue line in the middle. And imatinib with interferon, which is this gray line here, falls somewhere in between. But these curves are sufficiently close together that the differences are relatively small. So obviously this curve down here at the bottom, which is interferon first and then imatinib, is not as good. So this tells us that everybody should start with a TKI if they can. But all of the other curves run very close together. So using a higher dose of imatinib can improve the chances of a deep molecular response, but it doesn't change the chances of being alive on treatment. The other thing to point out from this study is the actual dose that people got. So some people were allocated to imatinib 800 milligrams a day. Some people were allocated to imatinib 400 milligrams a day. But what people can actually take varies significantly because of the potential for side effects. So when you look at the actual dose, for those of you with good eyesight, you can see that already in the first few months of treatment, the people who were allocated to receive 800 actually received about 550 on average because they missed doses or because they simply couldn't take the full dose. So you can see in the first year of treatment, the average dose for the 800 arm was actually about 600. So that tells us that imatinib 400 is very well tolerated. Imatinib 800 is a struggle. Not many people can take imatinib 800 milligrams a day. Probably the optimum dose is 600, that most people can take 600, but not many people can take 800. And that's interesting because in Australia, the Tidal studies, which I'm not going to be talking about, which were designed by Tim Hughes, he picked 600 just because it seemed to him like a good idea. But in fact, years later, we found from other studies that 600 really is about sort of the maximum dose that people can tolerate without too much in the way of side effects. So switching gear now to the newer drugs, to nilotinib and dasatinib. So the ENEST-ND was the major study from Novartis comparing nilotinib at 2 different doses with imatinib at the standard dose of 400 milligrams a day. So that's imatinib 400 milligrams a day as the standard arm, and then nilotinib 300 twice a day, which is now the standard dose in most countries, versus nilotinib 400 milligrams twice a day, which is still used for patients with resistance. So what you can see is that if we talk first of all about survival, there was really very little difference in overall survival between the arms. So like the German study comparing different imatinib combinations, the chances of being alive are so good on any of these drugs that it's hard to improve on it. If you look in more detail, you can see that the numbers of patients in each arm of the study are almost identical, but the number of deaths among patients treated with imatinib, 14 people died from CML-related complications, mostly from progression to accelerated phase or blast crisis. The number of CML-related deaths was substantially, So the number of CML-related deaths was reduced to 4 or 5 by treatment with nilotinib, but it came at the expense of a slightly higher rate of non-CML deaths, which means that the overall chances of being alive were really no different. In fact, they were slightly better on nilotinib, but not enough to be statistically significant. So again, if we look not just at whether or not someone's alive, but at how good a response the disease is showing, we see a slightly different picture. So here we see, again, the rate of deep molecular response, MR 4.5. And what you can see is that the rate of MR 4.5 on standard doses of imatinib was around 15%, 15 to 20% at 3 years. And this was almost doubled, so up to about 30% with either dose of nilotinib. So survival is really no longer a good way to look at CML because survival is so good with any treatment that it's hard to get better. So we have to look at other ways of seeing whether a treatment has actually achieved an improvement, and increasingly we're relying on deeper levels of molecular response to guide us in this decision. So what we can see is that people treated with nilotinib more rapidly achieve deep molecular responses, and as we'll hear later, these patients may have the potential to enter a treatment-free remission. And so if people have as their ultimate aim of CML treatment to be off drugs altogether and remain in remission without ongoing therapy, then maybe this will be important. And that's something that's really being worked on at present. Another point that was looked at was Socal score. So I imagine that most of you are familiar with the clinical risk scores. So the Socal score is the one which is most widely used. And this takes simple clinical factors like platelet count, spleen size, blast count in the peripheral blood, and age, which should be available for every patient, and divides people into a low risk, an intermediate risk, and a high risk group. And what you can see is that on imatinib, the number of people who fail to achieve a rapid early reduction in their leukemia is in the high risk Socal group is increased, but it's reduced when you switch people onto nilotinib. So here is the people who are not doing so, wrong way around. So the black is the people who are doing quite well, and the gray is the people who are not doing so well. So you can see that as you move from imatinib here to the 2 different doses of nilotinib, that the number of people who have more than 10% BCR Abel still at 3 months is approximately halved. So this suggests that if you have high-risk disease where your chances of having a very good response to imatinib are not quite so good, that these people might perhaps preferentially choose to be started on a second-generation drug rather than on imatinib because they're in this slightly higher risk group. Now here's the major upfront dasatinib study, which was called DECISION. So DECISION and INEST-ND both started around the same time, so they've got quite similar follow-up. So again, these are the same results, but each study has shown them in a slightly different way. So starting again with survival, your chances of still being alive, you can see there were 20 deaths in people treated with imatinib and 17 deaths in people treated with dasatinib, so virtually identical. And the chances of being alive without having progressed to accelerated phase or blast crisis was 91%, so 90.9 versus 91, so almost precisely identical between the two arms. So really, again, emphasizing that whichever treatment you choose, you're likely to have a good outcome. And again, if we look, this time they've used the Hasford or Euro score instead of the Socal score, and you can see that in the imatinib arm, the chances of achieving a major molecular response are a bit lower if you're in the high-risk group, and they're improved in every risk group by being treated with dasatinib instead. We also...
Yeah, is there any study of the tolerance aspect also?
So I've got some slides on intolerance later, so I'll come back to that question.
Sorry, can we reserve most of our questions? It's going to be reacted on during the Q&A after the three speakers have spoken. Thank you.
So, and you'll also see if we can, again, look at deep levels of molecular response. So here, MR 4.5, the rate is approximately doubled by switching from imatinib to dasatinib. So quite similar results to those seen with nilotinib. Now, side effects, of course, are a major issue. If you're going to be taking one of these medications for years or potentially for the entire rest of your life, then whatever side effects you have, you're going to have to live with for a very, very long time. You're going to have these side effects every day. And so even if they're mild, if you experience those mild things for 10 years, that's actually still quite a big deal for many people, particularly people who have busy lives, they have jobs to work, they have children to look after. So toxicity is hugely important with a therapy that you have to take potentially for the rest of your life. Now, it's very hard to summarize all of the studies and all of the different rates of toxicity because every study reports slightly different results. So I've just tried to summarize them quite quickly. So you can see that with imatinib, the major side effects are edema, so there's fluid retention, particularly around the eyes. Gastrointestinal side effects, so nausea or diarrhea. Some people say they have to rush to the toilet an hour or two after they take their tablets in the morning. Some people get muscle aches or cramps, and occasionally a rash. Low blood counts are seen with pretty much all of the drugs and don't differ greatly between the groups. With nilotinib is generally very well tolerated. The thing that stands out most with nilotinib is a rash, so there's a much higher rate of rash, which can sometimes be severe, and occasional people will have headaches. This elevation of lipase, which is an enzyme produced by the pancreas, is a particular problem with nilotinib, but only about 1% of people treated with nilotinib will develop pancreatitis. What I've not shown on here is impaired glucose tolerance. So people who are diabetic who take nilotinib will have a slight increase in their blood sugars, which will occasionally be enough for them to require a higher dose of insulin or their other blood glucose lowering medication. With dasatinib, the thing that stands out is pleural effusions, which occur in up to around 20% of people. And the pleural effusions are different from other side effects. With imatinib, when you start, if you're going to get muscle aches or diarrhea, they usually develop in the first month or so of treatment. But pleural effusions can occur even 2 years down the track. So it's quite different in that if you've made it through the first 6 months with imatinib with no major side effects, it's probably not going to change. But with dasatinib, you could develop a pleural effusion after 18 months suddenly out of the blue, sometimes apparently triggered by a viral infection or some other problem. Bosutinib I have personally never used, so I don't have a lot of direct experience, but the major side effect with bosutinib is diarrhea, very, very high rates of diarrhea, which is usually quite mild and controllable with antidiarrheal medication. And ponatinib, the so-called third generation TKI, has quite a high rate of rash, occasional episodes of pancreatitis, but the major problem with ponatinib has been a higher rate of stroke and other cardiovascular problems, and that led to the suspension of the development of the drug for a period of time, and it's now being investigated again using lower doses. It looks like the original dose was too high, and we think that people will do better with lower doses of ponatinib. So I've already talked a little bit about the sort of the special toxicities that pertain to each of the drugs. Recently, there's been some emerging evidence that people on imatinib for a very long time have a slow reduction in their renal function. So this is the glomerular filtration rate. So the GFR, so the level of kidney function, naturally declines a little bit with age, just like your eyesight declines a little bit with age and you start to lose hair. So it looks like the rate of decline in your kidney function is maybe a little bit accelerated in people who are on imatinib. This is usually not a major problem, but it's something that we see if we're monitoring people's blood tests over a long time. I've already talked about vascular events with ponatinib, but they're also a problem with nilotinib, where there's an increased risk of heart disease and peripheral vascular disease, so clots or poor circulation in the legs. Mostly we see this in people who are older or have other risk factors such as smoking or diabetes, but certainly in a Western population these things are so common that it's a major issue. I don't know whether in Asian countries you see less of a problem because you have fewer people who are overweight and maybe fewer people with major cardiovascular risk factors, but it is a big concern in Western countries. With dasatinib, I've already talked about pleural effusions. There seems to be a slightly higher rate of infection with dasatinib, so occasional people will get shingles, the reactivation of chickenpox, which can cause a painful rash. So that happens in about 5% or so of people treated with dasatinib. And there's another very rare lung side effect called pulmonary hypertension, which occurs, we don't really know what percentage of people treated with dasatinib, but it's probably quite rare, certainly less than 1 in 100 people. But that side effect is important because it's very difficult to detect. It's not something you would pick up with routine blood tests or clinical examination and can be manifest as shortness of breath with exercise. So the pleural effusions with dasatinib are one of the major problems for that drug. So I wanted to talk about this study which has come from the French group, which I think is one of the most exciting new studies in recent years. So this is the Optimum Study, which was a French-Canadian collaboration. And it came from the observation, they were tried to find out, can you predict, if you treat someone with dasatinib, which people will develop pleural effusions and which people will not? And what they found was that people aged over 65 had a higher risk, and people who had a higher level of the drug, shown here in this browny orangey color, had a higher risk of developing a pleural effusion. So they then designed a clinical trial to ask whether reducing the dose of the drug could overcome this higher risk. So what they did was they measured the level of dasatinib in the blood after a week of treatment, and in the B arm, these are people who naturally had a low level of dasatinib in the blood when they were measured 24 hours after taking the dose. And in the A arm, these people had a higher level, and the cutoff was 3 nanomolar. And then the A arm was divided, so half of the people were randomly allocated to stay on that dose, and half of the people were randomly allocated to reduce the dose of the drug until the level fell below 3. And what you can see, if you look at that randomization, is that you dramatically reduce the rate of pleural effusion by reducing the dose of the drug. So this is a validation of that previous study which shows that higher drug levels are associated with a higher risk of pleural effusion. So this is quite an impressive reduction from close to 50% down to about 10%. And most importantly, reducing the dose of the drug in these patients did not affect the level of their leukemia response. So here, these are the results at 12 months. So here we have people with an MMR, and each color is a different arm of the study, and you can see for every level of response, the results are essentially identical. So it didn't matter what dose of the drug you got. What mattered was the level of the drug in your blood. And I think this is one really very exciting study, and I think the one that has the potential to change the way that we use dasatinib. And I think maybe more people would use dasatinib if they knew that they could reduce the risk of pleural effusion. So I expect that other groups will want to reproduce this work to make sure that it's seen around the world, but I think that's really quite exciting. Another important theme in the last few years has been early molecular response. So we've seen I showed you at the beginning that graph which shows that people have a rapid early reduction and then a slower late reduction. So what we see is that people who have a really good response in the first few months continue to have a good response. People who don't have such a good response early on, sometimes they catch up, but sometimes they don't. And so these are a group of people in whom you might want to be monitoring more closely because they're at higher risk of things not going as well as you would like. So this is, again, from the ENEST-ND study. These are people divided into groups according to their BCR Abel level at 3 months. So you can see that the people with the lowest BCR Abel level have the highest chance of achieving a major molecular remission. So people who were less than 1% at 3 months, almost all of them develop a major molecular remission, regardless of which drug they received. So these are imatinib patients, these are nilotinib patients. Conversely, if you were in the worst group, where you were still more than 10% at 3 months, your chances of getting to that safe level of a major molecular remission are quite low. So here, around 2 years, it's about 30%, and around 2 years, it's about 20% with imatinib. So these are a group of patients about whom you would be much more concerned. And the same is true for dasatinib, shown here. The very interesting thing about this is that it almost doesn't matter which drug you got. Once you've fallen into one of those 3 groups, your outcome is pretty much the same regardless of whether you're on nilotinib, dasatinib, or imatinib. So it's how you're tracking in your molecular response that matters more than which drug you're taking. In the interest of time, I'll skip over this. The really important thing about early molecular response is that we've seen that if you fall into the bad risk group, that things don't seem to go so well for you, but no study has yet shown that there's a change that we can make to your treatment that will rescue you from that adverse outcome. So we know that it puts you into a high-risk group, but we don't yet know what we should do about it. So of course clinicians, because they want the best possible outcome for their patients, they're trying to make changes to treatment, but no clinical trial has proven that an increase in the dose or a change of drug will rescue patients at this point. So again, because of time, I'll skip over the selection of second-line therapy because I think that will be covered in the later talks. But the key point is that if you're resistant and you have a mutation, you should choose the next drug according to which mutation you have. If you don't have a mutation, if you're switching because of side effects or you have resistance without a mutation, then primarily we choose the drug according to the side effect profile. If you have a high risk of lung disease, you would avoid dasatinib. If you have a high risk of vascular complications, you would avoid nilotinib. So we really look at the person and what side effects that person has the greatest risk for and use that as the basis for our choice. So this is a drug which is currently in phase 1 studies. So GNF5 has been superseded by Abel Double O1, which is now in a phase 1 trial around the world. I know that a number of countries in the Asia-Pacific region are participating. So this is a completely new type of TKI that works in a different way from imatinib, nilotinib, dasatinib, and so on. And so what they've seen in the initial studies in mice, so where the mouse is red hot, it's full of leukemia. And where it's white or blue, there's no or little leukemia. So what you can see, these are the mice that are given leukemia but not treated, and these are the mice receiving higher increasing doses of the experimental drug. And what you can see is that without treatment, all of the mice have rampant leukemia after a week. And as you increase the dose of the drug, you start to rescue these mice. And these results are really quite impressive. If you combine this new drug with nilotinib, the results are even better. So instead of the mice all dying within 6 weeks or so of being given leukemia, you can prolong their life quite considerably. So we are starting to see results from this drug. It hasn't yet been published, but I suspect that at ASH we might see some results, and they really do look quite encouraging. So lastly, the European Leukemia Net, you're aware, is a group of experts from around the world who meet to decide on how we should be guided in making treatment decisions. So the European Leukemia Net define differing levels of response as optimal, where things are going so well for treating the leukemia that there's no reason to think that any change to treatment is required, and these people should have a normal or near normal life expectancy. There's failure, where this person is doing so badly that it would be unsafe to continue on the same drug, and these people need to change their therapy. And then in between, there's a warning group where we're not completely relaxed about how things are going, but things haven't clearly failed yet. And these people, because we don't really know what we should do, the recommendation is to watch very closely in case of impending failure so that you can make some changes if the need arises. And going back to this graph which I showed at the beginning, so an optimal response is less than 10% by 3 months, less than 1% by 6 months, and MMR, or less than 0.1% by 12 months. So that's summarized here. And then at any time beyond this, a rise in BCR Abel levels, the loss of cytogenetic remission, the development of accelerated phase or Philadelphia positive clonal evolution on a bone marrow biopsy would be signs of failure and a need to change treatment. But of course, those things are quite rare. There are alternative guidelines. The United States uses the NCCN, the National Comprehensive Cancer Network guidelines, which are similar to the ELN guidelines, but slightly different. And I'm out of time, so I can't really discuss. The major difference is that the Americans have taken the early molecular response, the 3 months, 10% cutoff, and recommended a change of treatment at that time point, whereas the Europeans have said you should just watch people more closely if they fall into this group. So really the results with all of the 3 commonly available TKIs are excellent, and the differences between them are relatively small and are mostly differences in the chances of getting to a deep level of molecular response, which might be a gateway to a treatment-free remission. Whichever treatment you use, monitoring the response to treatment is absolutely essential to getting the best possible outcome. And for those people who need to move on to another therapy, there are quite a number of promising treatments. So not only the ones already available like ponatinib, but also these newer drugs that are likely to become available soon like Abel Double O1. So I apologize for going slightly over time. Thank you very much.